Good afternoon, everyone. My name is Sherelle, and it's my pleasure to introduce the final panel for the forum today, where we'll be focusing on addressing global health innovation divide. We've heard a lot of numerous healthcare technologies being discussed over the past couple of days. And for this panel, we'll be discussing genomics, digital health, and related innovations in the context of global health equity. Despite significant inequalities in health status and access to healthcare globally, most health research and drug development is targeted at problems that affect only a small population of the world's population. In addition to this, health research capacity is concentrated in locations in North America and Europe. This afternoon, panelists will discuss to what extent certain technologies increase or decrease inequalities in health status and disease burden of populations in low, middle, and high-income societies. What types of innovation, including non-technological innovations, are priorities in resource-constrained societies? And how important is addressing structural inequalities that exist in healthcare research and development to bridging the global health innovation divide? Moderating will be Adia Benton, who is currently an assistant professor of anthropology at Northwestern University. Her recent book, HIV Exceptionalism, Development Through Disease in Sierra Leone, explores the personal, professional, and moral stakes of vertical funding for HIV and the social, political, and interpersonal relationships that are premised on the notion of HIV as a valued resource. Her work has appeared in Visual Anthropology, Medical Anthropology, the African Studies Review, Dissent, the New Inquiry, and the Monkey Cage blog at the Washington Post. She has provided commentary on global health and development politics, HIV/AIDS, and the West African Ebola outbreak on radio, television, and other public venues. Adia will be joined by Elizabeth Pisani, Agnes Binagwaho, Quarraisha, Abdool, Karim, and Astrid Christoffersen-Deb. I will now hand over to Adia to introduce the rest of her panel. Thank you.
Thank you so much for that introduction. I would like to begin by explaining a little bit about how this panel will go. We have two participants who are on the run after their panel, so we'll try to make it so that audience engagement can happen a bit earlier. The first thing I want them to do, however, is we'll start on this side with Astrid and work our way around, but to start by addressing specifically what way they're thinking about innovation in relation to inequality. I think we've seen throughout the past couple of days that inequality is the thing that we've been pushing up against or asking about, right? The social determinants of health as structural factors. So rather than sort of lamenting them, we'll actually start by using that as a starting point to talk about how we're thinking about innovation, technological or otherwise, to address these fundamental issues of inequality, or how we're actually seeing that in the work that we're doing. So we'll start here.
Okay, so I'm Astrid. I'm an anthropologist as well as an obstetrician, gynecologist, and I guess the perspective I come from is being Canadian but working within the Ministry of Health in Kenya for the last 6 years, essentially running with a neonatologist, what used to just be the maternal and child health program, and over the last 6 years it's evolved at different times to now become the reproductive, maternal, newborn, stillborn, child, adolescent health program, or primary care essentially for women and children, and it covers about an area of about 3.5 million people in Western Kenya. And so for sure, I've been in this position at a time when the global health space has really come to be defined not just by academics at universities, but more and more by industry people, and in the most recent iteration, more often by designers. And so without a doubt, all of the grants that we are writing and all of the funding and the expectations that are placed on us has now become like metrics and expectations that are like within that innovation sphere. And so we have adopted and tried out lots of these obvious innovations, from equipping community health workers with smartphones to see if it makes them smarter, not that much, to other innovations, which is using peer support groups in the communities throughout a woman's life cycle to see if that gives them the peer support, or rather peer pressure, to do the right thing and breastfeed exclusively, deliver in a facility, and immunize their kids, and that's one of the things that does work. But I think probably what's, where we are applying the innovation now is less on things and obvious products to thinking about the health system as such, and moving away especially from the way that we measure innovation and the timelines that are used in innovation to thinking of system-wide changes, and to that extent trying to avoid the sort of overrun space of pilotitis that tends to invade global health when everyone is just up to doing their 12 to 18-month pilot to show proof of concept, knowing that whatever you can show at 18 months is going to be very different from what you can show then at 5 years, or even now, like what I can see after 6 years of being there. And so at the end of the day, our innovation and our theory of change is really focused on the university as being the source of education, care, research, and innovation, and really trying to equip the university to be that innovative space more than anything else. So that's probably what I'm up to most of the time.
Agnes.
Good afternoon, everybody. I'm Agnes Binagwaho, former Minister of Health. I still say that because it was 4 months ago. But I guess that's why I was invited, because I hope you expect me to talk about which type of innovation we can bring in governance. And this is very important because this colloquium starts by how those great innovation we have doesn't touch the people on the ground. This is because governance is failing. And this is also because information doesn't flow correctly. Education is not done as it should be. And follow-up of practice also. So for me, I was in Rwanda. And as you know, Rwanda has done a great revolution in the way human development has been conceived. We came from a genocide period where everything was scratched, everything. And when I came back in '96, nothing was functional. However, we are one of the rare countries that has made the MDGs. We have universal access to health, primary care. 91% of our people have a health insurance. We have universal access to HIV treatment, and a better compliance and outcome than in New York and London. I'm very proud. How we make it? It is with innovation. And there is way also, not only in technology to make innovation, but to make all those great things effective to innovate in governance. And to do that, we need an academic approach, I totally agree. Evidence-based, accountability, and also a participatory process. Somebody says yesterday, don't do for me without me. Don't do for the people without the people. Don't try to do for them something they don't know, even if you know it's great. They will look at that like this. Also, we need to build trust. We were a country where trust was zero, and you can understand. If I was about to be killed by my neighbor, by a member of my family, I cannot trust. But we have rebuilt that trust. How have we done that? With innovation. Also, it was a country of segregation, discrimination. Of course, the biggest discrimination lead to a genocide. But today, the trust is there. Can I tell you with pride, because I'm a pediatrician, we have the best vaccinated kid on earth. All our kids, 93% of them, are vaccinated fully for 10 vaccines. We cannot do that without rebuilding trust. But when we have trust and participatory approach with the people, the community, everything is possible. But for this, we have to govern as a cluster. We have a cluster approach, 3 clusters only. The cluster in charge of human development, shared by the Ministry of Health. And inside, we have education, labor, disaster management, etc. And this is an innovation that helps things to fly. Other things that I can say, we still have a long way to go, but one area that should be neglected by no sector is the education sector and the academic sector. Education sector, we are building in Rwanda a university, and let me tell you, it's going to be the best on earth, and I'm not joking, because it's based on implementation science, on reality, on what we want to do on the ground, not only on fantastic study that will sleep in a cupboard and take a lot of dust for over years. Yes, implementation science, where we put the community in the heart of education, because everything is for them. That's it. And we still have a long way to go because our GDP is still not at $800 per capita and per year, what is almost nothing. But we are doing so well.
Right. I'm Elizabeth, and I was this morning speaking a little bit about something I know nothing about, which was drug development. Now I'm going to speak about something else I know nothing about, which is innovation. But bringing those two things together, I think one of the things that we didn't mention this morning, but is relevant to this, is that, you know, in the left behind disease, drugs, the left behind areas where we're not doing enough to develop drugs because there's no business model, blah, blah, blah. As we said this morning, we very often hear this phrase, NTDs, neglected tropical diseases, and those are the diseases for which we're not doing enough to blah, blah, blah. But actually, I think, as Agnes just said, it's not about neglected tropical diseases, it's about neglected tropical people. It's not the disease, and which we can fix with a drug. It's not the technology and the innovation that's going to give us a drug that's going to fix that disease. It's the systems that allow for the building of the trust, the people on the ground, blah, 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 which allow for that delivery. So the technical innovations, which we've heard quite a bit about today, are actually absolutely worthless without the innovations in, you use the word governance, I would say government. Governance is also a code word for the flip side of corruption. That's something that we need to be dealing with. I think we need to be dealing with a lot of those things. But my specific work that's more relevant at the moment is I've been looking a lot at the way data are shared in research in lower and middle income countries. And I was a big flag waver for data sharing starting about 10 years ago when I helped the Wellcome Trust get together a bunch of other big funders of medical research, NIH, CDC, the Medical Research Council, and 17 other funders from Australia, France, around the world, to state that they were going to require that all of the researchers who are doing research of public health relevance in lower and middle income countries would have to share not just their results, but their raw data in the scientific commons so that we could squeeze more knowledge out of the data that are being collected. And it was a beautiful idea, and they all signed up to this pledge, and then essentially nothing happened. And I've now been working on case studies of particular academic collaborations where that sharing has happened, at great cost and with great pain, and looked at really what the obstacles have been to that sharing. And the obstacles to that sharing are actually structural inequities in health research. And it's the structural inequities in health research that are to a great extent continuing the inequities in innovation, because the agenda is still being driven by academics in institutions such as this one. And one of the case studies I was doing is a very good collaboration, but because it's based at Oxford University, people who were in Rwanda and Kenya and Nicaragua and Indonesia don't actually feel that they want to share their data because the questions that are being asked are not being set by them. The answers that are suggested by the questions that are being framed, not by them, are not actionable by them because of cost issues, because of all kinds of other things. So I think we need to think in the context of equity and innovation about how we innovate in terms of our collaborations, research collaborations, so that we don't have increasingly, this is relevant to the last panel also, about big data and tech innovation, that we don't more and more have data being hoovered up from scientists who are just now primarily pumping out clinical trials to order from their partners in the global north, and having all the analysis and all of the, quote, innovation being done at a remove and a distance to meet agendas that are set by large funders such as the Gates Foundation, the Global Fund, and others.
Right, very good, Quarraisha. Please.
Good afternoon, I'm Quarraisha Abdool Karim. I'm an epidemiologist based in South Africa, and I study the evolving epidemic and focus on HIV prevention in young women. Yesterday, at the opening session, you heard that AIDS is no longer a threat, it's a chronic manageable condition. And we can celebrate that fact because of antiretroviral treatment. And that's a very good example of drugs that have transformed a condition that was inevitably fatal to one that is chronic and manageable. The use of antiretrovirals has also helped us to come to close to eradicating transmission from infected mothers to infants. And it's not just that we've had this innovation, but we've also, through novel public-private partnerships and government commitments, been able to translate this and scale this up programmatically with about just over 17 million people globally on antiretroviral treatment. But we have 37.5 million, as of 2015, 37.5 million people living with HIV. So that's a scale-up challenge we have. But what's of concern is that we are seeing 1.1 million people still continuing to die of AIDS, and we are seeing 2.1 million new HIV infections. So when we look at prevention, between 2013 and 2015, we have seen 0% reduction in new infections. And this is a big challenge because if we can't prevent HIV infection, we cannot think about epidemic control. So we do have a lot of tools out there, including the use of antiretrovirals prophylactically, in other words, by uninfected people to prevent infection. We also have knowledge that shows data that if you're on antiretroviral treatment and you have viral suppression, you reduce the spread of HIV. So when we look at why are we not succeeding in prevention, and particularly preventing sexual transmission of HIV, is that a lot of the issues and challenges, one is there are scientific gaps in our knowledge, and two is that the people who are getting left behind, whether they're in Africa or in other parts of the world where HIV continues to spread, are the ones that are being left out. They're being marginalized, they're being alienated. These are the sex workers. In some settings, it's men who have sex with men. But I want to focus on one particular group because 70% of these new infections that we're seeing that are taking place each year, and also people living with HIV, are in Africa. So when we look at the epidemic in Africa, what we see is that young women between the ages of 15 to 24 have up to 6 times more infection compared to their male peers. So this age-sex difference, where we only start to see HIV infection in men in their mid-20s, is very, very important in terms of the continued spread of HIV. So if men over 25 were having sex with women over 25, we'd see a natural death in terms of the spread of HIV. But because we have these young women having sex with men 5 or more years older than them, we continue to see the cycle of transmission. And here, innovation has helped us. Phylogenetic mapping of who is infecting who in large cohorts have helped us unravel transmission dynamics. Although sexual transmission is the least efficient mode of transmission, we see very high rates of high incidence rates in young women, up to 12% in some communities. And microbiome analysis has helped us understand the importance of a healthy genital tract and the importance of lactobacilli dominant environment versus non, and how the non-dominant lactobacilli environment enhances the presence of 5 or 6 pathogens that increase inflammation and thereby facilitate HIV acquisition. We've learned from proteomics analysis the importance of a healthy genital tract in terms of efficacy of interventions, including the use of PrEP. But I want to come back to young women. And I want to give you some insight in a rural community that I work in, which has about 500,000 people. By age 16, 1 in 10 is already infected with HIV if you go into the antenatal clinic. By age 18, that's 1 in 5. By age 20, it's 1 in 3. And by age 24, it's every other woman. Okay? Now, why is that even important? Because in Africa, it's the only continent in the world where more than 60% of the population is under the age of 30. And if young women are being decimated even before they reach adulthood, we are talking about major social incohesion and instability. So what is the worth we're going to put on young women, and what is the value we're going to put on young women, and particularly in Africa, to change that? And there are lots of innovation opportunities there, specifically focused in this group, that needs to be addressed.
Okay, thank you. So I actually wanted to add a few different themes that I heard, and I will try to begin to tease them out and then open up you guys for some answers. So I heard a couple of things. The first one is about the public-private partnership and the inequality embedded in those. And so that's the first question I have. One of the contextual pieces that I'd like to discuss, just as an example, is during the Ebola outbreak in West Africa, I heard a lot of modelers complaining that one institution, so in collaboration with WHO, only one institution had access to raw data about patients, which could have been useful for trying to allocate resources. This caused a lot of problems as those people started to publish papers in journals that were supposed to only publish open access data, things on open access data. I will not name the institution, but anyone who's familiar with the situation knows what that's about. The second is that Johanna Crane has recently been writing about public-private partnerships in relation to the systems, the governing systems that dictate donor beneficiary relationships. So in other words, she's actually looking at indirect costs allocated by the US government in their partnerships with academic institutions in the US and academic institutions in Africa, which are also very, so as an anthropologist, I'm interested in the culture of these institutions. I'm wondering if someone, I know Agnes has a lot of experience negotiating this as well, but I know Elizabeth has been talking about this. I'm wondering if you two might share more details or experiences about the power relationships involved in these public-private.
The power relationship is there, no doubt. If you are a country of $11,800,000 per capita against a country like the US, of course, when you're on the table of negotiation, you are the little mouse. Don't forget that it's not only in Hollywood that a little mouse can make an elephant afraid. It's not only in the little movie for kids. You can make it. The power you have is the power to say yes or no. If they give money for something you don't want because it's poison money, just say no. If I'm thirsty and you give me a glass of water with cyanide inside, I will say no. So money is not the solution for everything. Money is the solution if it enters in your action plan, in your strategy. If it's to do the strategy of Washington, London, Paris, etc., let them keep the money. When you say that, at the end, they give you the money you need. Because, why? They want success, you know? everybody likes to go to the Congress, to the Parliament and say, I have put my money there and it works. So they like to come when there is success. So play on that. So, like the US, we had a big issue of education for historical reasons. What we did, we negotiated to divert a lot of money from PEPFAR, a lot, and contract US institutions for education. And say, we stop, we can give the pills ourselves, we can educate ourselves, leave all this. We want a new technical assistant education. So we contract 23 universities in the US to have 100 teachers a year for a year, for them to mentor our medical school, nursing school, etc. Half of them are nurses, half of them are doctors. And in the beginning, they just laugh and say, never, okay, nothing else. Huh? Never, nothing else. In the end, they say, okay, let's see. And in the end, we had our 100. And it's the third year. We hope it will continue. But in the beginning also, in 2000, when I started in the National AIDS Control Commission, I just say, I have no reports here. Tell me who is doing what with the US money. It was a lot of money. And they say, no, it's classified. I say, what? They say, no, it's classified. We cannot say. So I say, at that time it was President Bush, and I say, so you don't want me to tell to President Bush to how much I should be grateful to the American people. And they say, I give you 1 week to give me the report, or please, you can go back home. They just look at me and to the others and they say, but she's crazy. I said, no, I'm not crazy, I'm at home. And at the end, they give us. But now they like it, because when we are together with transparency, we achieve more. And they can go back home with better results and better applause from their people. And for us, we achieve more. So the power is what you believe. Okay. If it's no, say no.
But, so you are a legend. You are a legend, and I'm very proud to be sitting here with a legend. I can only think of one other example, which was when Brazil said no to $40 million because of the sex work clause in PEPFAR. But it's very, very, very rare that countries do that. So first of all, you're assuming that they want success on the same measures that you want success, which I would argue is not always a fair assumption. And number two, and you said it yourself at the beginning, you started from zero. Rwanda was starting basically from tabula rasa. So they were not coming in to a framework where there's a lot of already existing national institutions that are fighting. The National AIDS Council wants this and is fighting with the Ministry of Health who wants that, But it's, the fact is that you say that as if it's an easy thing to do, and yet no one has done it except for you. So why do other countries just not say, you know what, your money is, take it?
No, I don't. No. My mother will not allow me to do that.
Sorry.
But I do that in a very polite
You said it very politely. No, it's true. It's an important point.
The manner counts, First of all, I will not say, no. I think you have to put the deal on the table as a win-win situation, not like that. No. If you do that, you hurt and you need to negotiate. So maybe at the medical schools, we need to have advocacy course and negotiation course. I advise you, it will help also with the client we have. But the most important is the way you manage to frame the win-win situation. That's maybe the skills. Never do that to anyone.
Can I ask? This is something that I actually noted in my book. I actually said, because someone, I don't remember who read the book, but he said, oh, but Rwanda. And I said, oh, but Rwanda is an exception and not the rule. I've been sitting in the negotiations in Sierra Leone. Astrid, do you have something to say about your place in Kenya?
What I would say is that, at this, you're talking at a very high level, which for most of us is not going to be within reach. But I think more often than not, our funding sources, whether it's for academic research or implementation science, now is coming with conditions that you as an advocate or as a researcher may not necessarily want to fulfill. And so In part, it comes from, let's say, particular grants that'll say we need to show success in child development by 18 months of this intervention, right? And you can argue, well, you don't see improvements in child outcomes by at least age 3 or probably by kindergarten age, right? And so I think like what Agnes speaks to is really like the need to sort of be creative and think of sort of where is your funder or who are the people that are involved in that conversation, and trying to optimize your situation by being innovative about how you approach that funder, how you think about the metrics of success, how you think about your intervention, and also over time to avoid those funders that can't work with you.
Yeah, so packaging the metrics of success, as you say, is
I want
really
to recall
important.
that Rwanda in 1997 threw out 600 NGOs. Out, go, the airport is there, we give you a car.
See, I would have just said this, but she gives them a car.
Very politely. And they told us, you will never survive. And we just think, we will survive. And we survive. We need to take a risk because we know where we go if we do business as usual. Never do business as usual.
Yeah.
And it also, so which means that we also have to know what business as usual is.
It's failing.
It's because I think one of the things that I've been struggling with as an anthropologist is so many anthropologists, so many of my ilk want so much to focus on the local, which is fine and great, but we're not all, the local for many of us is actually at this level that we're talking about, this level of governance. Yeah. And so the public-private partnership, the negotiations between the Ministry of Health, the level of the NGO, what is business as usual? How do we define that? What are the obstacles to making the kinds of change that we're talking about here?
But there's a cultural thing, right? With, I mean, young girls being exposed is business as usual.
Right. So perhaps Quarraisha can actually expand a little bit about the kinds of what kinds of innovations you might have been thinking about when you were talking about the young girls, the adolescents.
So I just wanted to make a couple comments. The one is that we shouldn't paint all public-private partnerships with the same brush, because there are some good examples. Okay. And also, I think the issue of what you do and how you do it when you're working collaboratively is that you do have power to negotiate that. And if you want to compromise it and do anything when you know the outcome is not possible and so on, that speaks to another aspect and facet. But in terms of innovation, the point I wanted to make is that even with young women, the technology is the first step to ensure survival of a particularly vulnerable group so that they can grow up and reach adulthood healthy, HIV-free, not having babies during teen years and so on. But we have to ask, what are the fundamental root causes of that vulnerability? And that innovation allows a space for something to emerge so that other aspects and facets can be looked at. So when you have a society that condones adult males 30 years old having sex with a 14-year-old or 15-year-old, that's not an innovation problem. Mm-hmm. That's a value problem in that society. So it's about what are the social norms in this community, what is acceptable norms and values. The same when we have gender-based violence, which is also very common and growing in many of our communities. The most vulnerable is actually these young women under the age of 18. And to add to their vulnerability, we exclude them from research if they're under 18. Right? So this is a group that needs to benefit most. We exclude them. We exclude them because we need consent, we need assent. It's all very complicated, you know, they're unreliable, all kinds of things. So we got to blow that one out in the innovation context. Two is that in thinking about technologies, I would also add pregnant women, and particularly in the context of HIV, uninfected pregnant women. So we focus on the positive women, and we leave the negative pregnant women because we're not really interested. She doesn't pose any risk to the fetus. So it's again the value of women that we put. Is it the fetus that's important? Is it the survival of the fetus? Or is it the survival of the woman? So there's a lot of gendered aspects here, and I don't want to belabor the issue. I think I made my point. But when we're thinking innovation, when we think about developing new technologies, whether it's drugs or devices, so on, our bar and gold standard is a white Caucasian male.
Yeah.
And then when that product comes to market, all of us use it. Pregnant women, non-pregnant women, women in the US, in Europe, or everywhere else. And we've slowly started to include women who are on some reliable form of contraception, and they have to be over 18 and a whole lot of stringent criteria. And this creates challenges in terms of development of new modalities that has to be used by everybody across the globe.
Can I just say one thing? It's a very nerdy thing, but for those of you thinking back to the last panel who are data scientists or aspiring to be, I think that this is one of the really interesting things. So you're right that the research model has been badly broken by being focused on white Caucasian men mostly, and in psychology, white Caucasian university students almost exclusively. One of the interesting things about some of the most effective big data and data sharing partnerships has been that you get all the mistakes. You get the people who shouldn't have been recruited into a clinical trial, but were recruited. So you get 3 pregnant women here and 1 pregnant woman there. And obviously, and they weren't supposed to, they were supposed to be excluded, they got in and they kept the data in there. But you can't do anything with an N of 3 or an N of 1. But if you put 135,000 patient records together, as the WARN, the Worldwide Anti-Malaria Resistance Network has done, for example, you suddenly think, oh, in this cohort, I have 800 pregnant women, and then you can start to look at stuff. So big data is actually sometimes quite a useful way of looking at the margins, the people who've been historically excluded. If you put enough data sets together, you sometimes get a lens on the excluded. A very nerdy point.
But also you're learning about it like post-licensure. It's much nicer to know these issues.
Of course, I'm not saying it's not a solution. I'm just saying it's a stopgap.
It is.
No, you're quite right.
That's so interesting because although those are, fine points, I think this also points to other questions of value, right? So when you're talking about values, you're not simply talking about, say, the values of the people in the communities under watch or intervention, but the values of social scientists, of data scientists, the values of people running clinical trials, the values of donors and ministries, and the values of, there are a lot of values that you also had, the different perspectives. And so I'm actually wondering, how are we doing on time? I'm totally...
It's okay.
It's okay? Well, I also want to make sure, because I was informed.
It's okay. It didn't move yet.
Yes, good. So, I wanted to make sure, too, that we also had time for audience participation, because I'm sure that there are people who have specific cases and questions. So, is it possible for us to open it up to the group so we can start talking? I'm curious about your values, actually, how you're reading this. Yes.
Up
There's
to
a
you
person
now.
right here.
Thank you very much.
For the camera.
I was just wondering, is this on? Yes. I'm just wondering, at the beginning of the panel, we were talking about how innovation tends to come from countries that have more money, and then lower income countries tend to have, they don't have direct innovation agenda. But I've noticed that there's a pattern in global health granting organizations that focus only on lower income countries, is the same lower income countries that are always receiving the grants. Different hypotheses have been made as either certain countries know how to fill grants that these global health organizations
Astrid, I think you started with the university, so I'm interested in that.
EMPATH, which is who I work through, the academic model providing access to healthcare. We really believe in the university being the center of care, education, research. We are supposed to be the engine, and as all of us are here, I would assume that most of us are disciples to that kind of an ethos. And so I think what you will find is that with the grants that are going, or where they are most likely to succeed, is where you're going to have a university structure, and more often a university structure that has a collaborator in places where they know how to succeed in writing grants and getting them. And so if I look at sort of the 30-year evolution in the collaboration with Moy University, it has really been possibly the first 15 or 20 years where most of the grants were written through Indiana University, University of Toronto, Duke, Brown, in the name of Moy University. And then now over the last 5 years, it's Moy University scientists and researchers and students who are actually now submitting the grants themselves in their own name and putting them together. But that's the sort of lifeline or the timeline that you need to be able to see that change. And then obviously there are places that know how to do it well. Kenya is kind of like its own version of San Francisco. We have the internet, we have great collaborations, we have the relationships, we have pre-existing funding, and so it makes it a lot easier for Kenya to actually get some of those grants compared to a country like Niger, for example, that won't. And so there's a lot of factors that go into it.
And I think just to add to what Astrid said is that, as Agnes described, it is about power relationships. And in some instances, you see, the power being in the hands of the scientists from the north, and in some instances, it is the same. It remains the same 3 decades later. And then where you have true collaboration and partnerships, where both are really contributing to the knowledge generation process, you see that transformation happening. But some people also feel comfortable in the subservient position. I get my grant, I don't have to think and do it, I'll just be your data collector. Right. So unfortunately, the data collection piece is dominant, and we've got to change that paradigm.
Absolutely. When I was, I passed a policy stating that to do a research on Rwandan people in Rwanda, you need to be in Rwanda first, not tele-research, what many people are doing. Second, you need to have a co-investigator that is Rwandan. Third, you need to use that to educate Rwandan. Fourth, you can publish about it. 1 publication from somebody from the north, 4 publications by somebody from Rwanda. Just to oblige the partner to educate Rwandan because they want to publish. It's not that I want to block, but that's the only way we have seen things going. If not, all our people were transformed in data collectors. Yeah. And at the end, nobody wants to enter in research because they are abused. Now the collaboration is fantastic. Many Rwandan won prize, many American won prize. They are together, and really there is a true transfer of capacity because it takes time, it takes commitment, and it takes energy. But there is so much to publish, to study, and to do. But very few people from the north take that time if there is no regulation.
Success breeds success. I'm not going to answer your question directly because I think it's been very well answered, but the question of how does innovation come up in lower and middle income settings is basically through champions, and we've got one sitting right here, who suddenly sets an example that then other countries are like, okay, that woman from Rwanda, she's on every panel, she gets invited, she gets these prizes, she gets invited to speak this and that. What do I have to do to be like her? And we see it a lot so I do a lot of work in Indonesia, which is a upper middle income country that went from being one of the most centralized countries in the world to being one of the most decentralized in the space of a year and a half. Total chaos. It decentralized to the level of now even the government doesn't actually know, but maybe 519 different districts and cities. Each of those districts and cities has its own autonomous health authority doing their own thing. It's utter chaos. But out of that chaos has come one or two things led by one or two people. So there was a guy who was a vet by profession, who was from East Java, but stood for to become the district head in Bali, in one district in Bali. And he wasn't part of the political mafia. So Indonesian politics is deeply, deeply transactional. But he wasn't part of the mafia. He kind of came up almost by mistake. So now he's like, oh, okay, how am I going to stay in power and whatever? I'm going to have to actually appeal to the electorate, which was a brand new idea in Indonesian politics, actually do something for people instead of for the entrenched elites and this and that. And what he chose to do was health insurance, universal health insurance. And he developed a model of universal health insurance in this one district, and then he was Tempo, which is like Time magazine equivalent, Man of the Year, and then he was invited to the President's Palace and this, and now the must-have democratic and electoral accessory is a health insurance policy. So then they're springing up all over the country. And then the national president said, wow, this is really popular, and maybe I could make myself a bit more popular too. And so it's been subsumed at the national level. And Indonesia has gone from having about 16% health insurance coverage to about on the order of 68% in the space of 2 years. It's a miracle. But it happened from that innovation of extraordinary leaders in extraordinary circumstances, trying stuff out and then creating success, which is then emulated.
And if the circumstances are not extraordinary, create them.
Yeah.
Quite right.
It also seems like the innovation is an eye towards equity, at least in this part, right? What you're talking about, this, you really have to try to ask where the nodes are of inequality and inequity and try to actually transform them, right? So are there other questions? There must be. You have these people up here who are eager to talk about these things.
We stunned them into silence.
How did you stun them into silence? Is it a caffeine issue? What is it?
Equity make you afraid?
I have to say, speaking of equity, that I don't support single gender panels. In fact, I don't go to any single gender panels, and somehow
There is
Managed to.
this gender's okay.
Yes.
Hey, friends. So, Trump.
Trump. Was that the question? Electoral accessories or
My greatest fear is the extended commodification of women in the Trump era. And that's just going to exacerbate the disparities we see in the gender disparities.
Yeah. I mean, to add
Fire
to
back.
that.
Fire back. We know what is the risk when there are such public statements. So I hope that international global fighters will fire back, because it's not because you are the most powerful man in the planet that you can do whatever you want. Don't give up. It's not done. It's not because there was those statements that it's going to lead the world. The world will be led by the people who fight for the right thing, if they are not sleeping.
Yeah.
So it's not a question. It's the beginning of a fire back. You disagree?
No.
Actually, Astrid, did you have something?
No, I mean, I was just going to say the same, is that, we've already gone through eras where, we were already anticipating the end of PEPFAR in the coming year just because of changes in Congress, and with that comes a big focus on organizations that are international, but also even just domestic, to try and find other sources of funding or find ways to continue their commitment for us, the health of women. And so for us, it's been access to contraceptives. Depending on the presidency, it comes and goes, but in being part of a Ministry of Health system, you're supposed to keep yourself immune to those changes and say, this is a rights issue. Women have a right to appropriate contraception during their life cycle, and that just has to be made available, and you fight for that regardless of who's been elected in DC.
Can I also add, so I happened to be working in DC when George Bush was elected, and I worked for a reproductive health organization. And one of the things that we did, I remember going to the USAID offices for the programs that we were working for, and they actually sat us down in the conference room. Actually, they might have come to us because they probably were afraid to have this meeting there. They said, this is what the new policy, the new administration does. This is what it's interested in. We can't talk about sex work. We can't talk about this. We can't talk about that. But let me tell you what you can talk about, so that you can still keep doing the work that we think is amazing and that you can keep doing, because those are the people who actually don't change. Those program officers are in that office. They still have the same agenda. They still have the same interests. I know we're being recorded.
So,
so you have your allies in those places.
So be ready to change the narrative and the vocabulary and do the same, more hardly.
Yeah, so family planning becomes birth spacing.
Absolutely.
Right. Everyone's behind that.
And strategic thinking for doing what he said he do in the bus, I don't know what.
It's knowing what is there. There are now other questions. Yes, there's a woman here in the front.
And there's a man in the back with the microphone.
Okay, there's someone with the microphone in the back. And on the side.
Illustrator.
Oh, the illustrator, please.
Yes?
Yeah, I go to illustrate things all around Europe and lots of different businesses. And this year, one of the things that struck me was a game changer event where foresight people from around Europe came together to predict big mega trends for 2050 and beyond. One of the most terrifying things they talked about was a global pandemic that could probably wipe out anything up to 40-50% of the world's population. That's being seriously considered a model by various governments around the world. And I assume that developing countries could, if you look at Ebola, be ground zero for that. So, is there anything that we learned from the Ebola crisis and that sort of thing that can help us feel a little bit better about this really disaster that may or may not happen?
Who wants
The first thing that we can learn from the Ebola crisis is that sharing information very quickly is always a good thing. And that holding onto it for the purposes of whatever, for furthering your academic career or registering your patent first or whatever is always a bad thing. The second thing is that actually, people who do those global, whatever, what's come, futurology, what do they call it? I think have the jammiest non-job in the world, and good for them, hurrah. But for those of us who actually are looking at what might happen, I think that Ebola was not that unpredictable, and there are very good scientists, including in this university, but all over the world, looking at some of the things that are likely to be the cradles of, and it's some zoonotic diseases. Antimicrobial resistance is a big one. These things are not coming out of nowhere, mostly. So I think that we can build on systems, and particularly better systems of global communication and coordination that we learned how broken they were during the Ebola crisis. I think we can work on strengthening those to preempt some of the more predictable things. That's already happening with antimicrobial resistance.
I have adolescents. You can never overcome a threat, whatever, if you don't have a system. That's one. So we should stop talking and build a health system. Before bringing whatever in, build a system and help country to build a system that is near the people, decentralized, and where the people has a participation. Second, Ebola was not maybe predictable. It was predictable. There are publications, 72, 76, 82, by the Tropical Institute by Germany, by Columbia University, and by universities in this country about the antibodies of Ebola in the blood of people in Guinea and in Liberia. So we knew, however, it was non-open sources. No people from Liberia and Sierra Leone had access to those journals except paying the equivalent of a salary of a minister in Rwanda to have access to those journals. You see what I mean? So we need to promote open sources, circulation of information, and stop to be an amnesic race of human beings.
All right, so we're running out of time. We're going to take, can we collect two? We had two people, so can we just collect those two questions and then try to answer them quickly, briefly?
Hello, hi. Yeah, thank you for the talk. It was great. There was, in the very beginning at the introductions, there was some discussions about innovations in governance, and I just wondered maybe if you could perhaps elaborate on some of the ideas that they had in that area and how to innovate in that space.
Okay. Innovation in governance. And could we collect this other, yes?
My question is very similar, which is that increasingly global health is becoming innovative, and part of that's because there's increasing interest from the private sector and also big philanthropic organizations like Bill and Melinda Gates Foundation. At the same time, which is being criticized. I'm wondering who you think will be setting the global health agenda over the next 10 to 15 years and the potential pitfalls of that.
Okay. So
I'll just answer the last question. Oh, there's one more? Okay.
Health organizations, global health organizations, set targets for areas where they'd like health to be improved. Often in the areas where the governments and specifically in the countries there are not communicating with their neighbors, collaborating. How do organizations interact with governments who themselves are not interacting with their neighbors? And how does the international community foster communication between governments or countries that are not communicating to better health within a specific or large geographical area?
Okay, so we'll collect those questions and I'll try to direct them accordingly so who wants to answer we can start with the innovation in governance?
So, for the last question, there is no more country that is standalone, I don't remember. They're all, we are in East Africa. We are in African Union. We are in COMESA. They all have a council of ministers. So that means, as an association, you can, if you find that you face a country where they are failing to listen to you and to act properly, all those institutions has a secretariat. Put the question in the secretariat. There are always ways to do things. If you have problem, you have my email. The other thing, I don't remember or follow the other question.
Who should set the global health agenda?
People. If you are not on the table, you'll be on the menu. Yeah. Be on the table and set the agenda with the people. You see? So we are there. We are here for global health. That means we are there to set the agenda. And you have a voice, you know? And they are listening to you. It's just that people believe that they have no voice. They are not big people. They are just people. Your bank account doesn't determine who you are. If, of course, somebody pay your ticket to come and talk about it. But everybody, we are there. Universities are needed. People are needed. Workers, health workers, we are all needed to set the agenda because nobody has everything right. We are right if we are together. And governance, I don't have time because I have to catch my plane, but governing cluster, participatory process, evidence-based, accountability, geographic equity, gender equity, financial equity. If you mix that, you'll have a good cocktail.
Does anyone up here have anything to add to the innovation recipe? The cook, the pots. Okay. Thank you, everyone, for hanging in. Thank you, panelists.